Hello guys, it's Dr. DeShavo, and we are back with the second part of blood. I don't know why I like saying it like that, but sorry if you don't think it's funny. I don't know. I try to keep things a little interesting. Anyway, moving on to something that should sound familiar, infectious mononucleosis. I don't think it's super common, but when people have it, it's pretty intense. If you've known anybody who has had it, it really knocks you out for a long time. And it's known as the kissing disease, but really could be the spitting disease because it can be transmitted through spit. So if you share cups or glasses or, toothbrushes, or whatever, you can transmit it that way. But of course, people like to call it kissing disease because it sounds funny. Self-limiting, it is viral. Caused by the Epstein virus, which is actually in the herpes family. But self-limiting, it will cure itself after a while, but that can be months is the difficulty with this. Most prevalent in adolescents and young adults. I have seen this in a 60-year-old man, though. So it's not necessarily just young kids. It can happen in older people, too. It'll infect the B cells, which once again are from that lymphoblast lineage. And it'll be incorporated into the B cell's genome. And those produce abnormal antibodies called heterophile antibodies, which can be shed and detected in the blood. Once the disease is eliminated, we can actually retain a few of those altered B cells, giving that person an asymptomatic infection. And so that's why, I knew somebody who had this in high school. Nobody else had an active case of it. Somebody had a latent form of it that they expressed to her, unfortunately. Insidious onset, incubations 4 to 8 weeks. Weight loss, tired, chills. They present as being sick initially. But then with a sore throat, but then that illness continues. And if it goes beyond your typical, 10-day approximate infectious period for normal colds and illnesses, if that continues, you want to test them to see if they do have it. And of course, there's not an actual BAM treatment for it, unfortunately. You just have to treat the symptoms. So, infectious mononucleosis is only communicable with kissing, is a rare virus, is a quick-moving infection, and is found to affect B cells. What do you think the answer is? Put a little Jeopardy music in the background from now on with the questions. Moving on to lymphomas. So these are cancers that affect the lymphatic system, and the two main types are Hodgkin's and non-Hodgkin's. And this is one of the most common blood cancers that we find in the U.S. So we're going to break it down into Hodgkin's first, which is the least common of the two, but the less aggressive of the two. It's very curable with treatment. The presence, I have a feeling that probably your boards are going to like Reed-Sternberg cells. I don't know why. I could be wrong. But these will be found as abnormal B lymphocytes. So these are B lymphocytes which get affected by the lymphoma, and they grow to be much bigger, and they have an owl eye presentation. They look like they have two nuclei that look like owl eyes. So Reed-Sternberg cells. They're found in Hodgkin's, but they're not found in non-Hodgkin's. That's how we differentiate between the two. There are several subtypes of Hodgkin's. We're not going to get into that. We're just going to talk about it in general. Now, once again, I'm not going to get too crazy on diagnosis and treatment because I know you will get into that in the future. But one of the things to really note with this is painless enlarged lymph nodes, especially in the neck or the upper part of the body. And of course, the list of anything on here, fever, night sweats, chest pain, night sweats is a good one to note as well, recurrent infections, any of those, chest pain, coughing that's persistent, you should always have someone checked. It's a sign that something is not going correct. Now, staging, I think a good way to remember the staging is location and number. So stage 1 is 1 lymph node or part of a tissue or an organ. I would think it would be both. Stage 2 will go with 2 lymph nodes, usually above the diaphragm. That's going to be the big difference between 2 and 3. 2 will be usually just 2 lymph nodes above the diaphragm. 3 is when we get more than 2 above and below the diaphragm. And you may get a little bit of a spread to the organs or surrounding tissues. 3, as I said, will be above and below the diaphragm, and those lymphoma cells will be in one part of a tissue or an organ near these lymph nodes. Can also start to get cells found in the spleen. Stage 4, it starts to spread. So we'll have multiple lymph nodes and spreading into tissues above and below the diaphragm. And recurrent will be a recurrence after treatment. Diagnosis, you can read through those on your own. I think you understand and know most of those, and chemotherapy is going to be your first line of treatment. But once again, I won't test you about this particular one. When it comes to diagnoses and treatments, I'll name them specifically when I want you to know them. I'm just keeping them in from your book because there's so many of them, and I do think they are helpful. Right, so question time. Which letter represents stage 3 Hodgkin's lymphoma? Remember how I explained the differences to you? So, and remember that 4 would be more progressed. So take a minute, look at that. And we are moving on. So non-Hodgkin's lymphoma, excuse me, is a little bit more common with a poorer prognosis. And the main difference with this is you're not going to have those Reen-Sternberg cells, excuse me, and it can originate in the T or the B cells, and it tends to spread more. So it tends to be wider spread rather than those specific stages, those 4 stages with Hodgkin's, you know, one being one lymph node and a little bit of spread, etc. This tends to be wider spread. And this is why it has a poor prognosis, because obviously the wider something has spread, the more difficult it will be to treat. Now, this is kind of backtracking a little bit, but as I start moving into leukemias, I want to explain to you the difference in the creation of blood cells from a stem cell, from a hemocytoblast. So this is called a multipotential hematopoietic stem cell. Whoa. What that means is it has a multitude of potentials because it will divide into all the different blood cells that we've spoken about so far. And how we divide them is into 2 major groups. There's the myeloid progenitor stem cell groups and then the lymphoid progenitor stem cell groups. Or I should say cell groups, because at that point it's not really a stem cell anymore. So if we look, let's keep the list simple. If we go down into a lymphoid progenitor cell line, what happens is we will create T cells, B cells, and natural killer cells, which I'm not sure I've gone over those, but those are basically a huge mambo. I believe it's actually a T lymphocyte, but they just have lymphocyte here, that goes around and kills off infectious agents. And from those B lymphocytes, as we've gone over already, we get those plasma cells, okay, which can help to create the antibodies. So from that lymphoid progenitor cell, we're going to get all of our lymphocytes and their derivatives. Let me clear this. Okay. Coming down to the myeloid, that's going to be everything else. It's going to be erythrocytes, which are your red blood cells. It'll be your mast cells, which help to produce histamine, which actually may be derived from another white blood cell, but anyway. And then this myeloblast is going to give us our white blood cells, all the other white blood cells other than the T cells, lymphocytes, I should say. Basophils, neutrophils, eosinophils, and monocytes. So just kind of keeping that a little bit simple. Yes, you do need to know this basic understanding of this, but it's pretty easy. From the lymphoid progenitor cell, we get the lymphocytes and their derivatives. The myeloid's going to be everything else, okay? Do you need to know myeloblasts? Not really. As long as you know that you get all the rest of the cells from the myeloid progenitor cell line. Okay, and the reason I put that in is because there's different forms of leukemia that are myelogenic or lymphogenic. Okay, so we'll get into this. So second most common blood cancer is a cancer of the leukocytes, which are your white blood cells. And what happens is they have an abnormally fast proliferation, which not only crowds your normal blood cells, it also creates immature white blood cells because they're created so quickly and they're pushed out into the bloodstream before they have a chance to mature. So you can list and read the list of causes and risk factors, but unfortunately sometimes leukemias just happen. So there's different types. There are 4 types that we're going to list in these next 2 slides. There's acute lymphoblastic leukemia. ALL is the abbreviation, and this is the only one that primarily affects children. And I always remember this. One of my teachers in chiropractic school a long time ago said she remembered it because there used to be a soap detergent called ALL. This is so stupid, but I still remember it to this day. And she imagines a little kid standing there pointing at it because it was actually on the commercial for this, all detergent. ALL. There was a little kid that would point to the letters ALL. That's how I remember that kids are prone for this, acute lymphoblastic leukemia. It's stupid, but it's stuck in my head. So hopefully it helps you. This is the only one that affects primarily children. Thank God it has a good prognosis and responds well to therapy. Acute myeloid leukemia is primarily adults. It does fairly well with treatment. A little bit worse of a prognosis than that of acute lymphoblastic leukemia. Now, there's chronic forms, which also tend to affect adults. So chronic lymphoid, we'll start with, responds poorly to therapy, but it's slow going. So most patients live many years after diagnosis. Now, chronic myeloid is also primarily found in adults, and this is also a poor response to chemotherapy. There's a little bit better of a prognosis with bone marrow transplant. So manifestations, leukopenia would once again be a decrease in white blood cells. Thrombocytopenia, don't forget that's thin or fewer, penia as a suffix, so this will be fewer platelets. They would have anemia because they're not going to have as many mature red blood cells created and put into their system. Swollen lymph nodes, joint swelling, possibly bone pain, weight loss. Weight loss across the board, guys. Anorexia are going out of the blue are bad signs, as you know. If somebody is losing weight, they're not trying, that's a bad sign. They need to be checked. Hepatomegaly, splenomegaly, or enlarged liver and spleen, and then central nervous dysfunction because you don't have the proper oxygenation. So those are all good things to know. Diagnosis, bone marrow biopsy, blood testing, and treatment would be chemo and bone marrow transplant. Multiple myeloma is a nasty blood cancer, and this will be plasma cell cancer. So this is going to affect those B cells that turn into plasma cells. There's going to be, once again, an excessive number of them in the bone marrow, which would also crowd the other blood-forming cells in the bone marrow. And I actually have a little video for you about bone marrow and the creation of blood cells in them. So make sure you watch that in your supplemental media, please. Now, in addition to not allowing the other blood-forming cells to mature, these cells don't mature as well because they're crowded in the bone marrow because there's so many of them. Now, the thing with these is they also release Bence-Jones proteins, and these are proteins that are released from the B cells that travel through the bloodstream, and actually can be excreted through the kidneys into the urine. So that's an abnormal protein that'll show up when we get these plasma cells that have turned cancerous in multiple myeloma. The other nasty thing that multiple myeloma does is it likes to destroy the bones. These abnormal plasma cells can actually destroy the bones around them, and you could get multiple dark areas upon x-ray. And the other nasty thing is this usually is not found until it's well advanced. So you'll have somebody come in with back pain, you'll take an x-ray, and unfortunately they have multiple dark lesions. You test their blood and they have multiple myeloma. Just a nasty, nasty, nasty little disease. So insidious onset, which means that you don't know it usually until you test for something else. That is something that I do want you to know on here. You know, it'll manifest as decreased bone density, bone pain. You'll actually have hypercalcemia because you're breaking down the bone. The cancer is breaking down the bone and it releases calcium from that storage of calcium in the bones itself. Renal impairment because you're going to have those Bench-Jones proteins going through the kidneys. That'll stress the kidneys. They won't function as well. And then anemia because you don't have proper bone marrow to create the proper amount of mature red blood cells. Thrombocytopenia, decrease in platelets because once again you're not creating the proper amount of platelets from the bone marrow. Leukemia, sound like broken record, decrease in the proper amount of white blood cells because you can't form them because they're all crowded in that bone marrow. And once again, diagnosis and treatment, you know, things I think that sort of spin off of what we've talked about already. Here's your question time. I'm trying to put a few more questions in to see if you're awake and paying attention. So, what disease is this? I want you to look at this x-ray and really think about what we've talked about. Would this be infectious mononucleosis? And just to help you out a little bit, if x-rays are not in your wheelhouse, not sure where you work in. We all work in different areas. We have different specialties. So obviously, if we're looking at this picture, here's the femoral head. Here, iliac crest would be up here. So we'd be looking mostly at a pelvis. Okay, and then sacrum would be back in here, right? And then it looks like they've got a shield down, the genitals down, a little low, but anyway. Okay, so infectious mono, B lymphoma, C non-Hodgkin's, and D multiple myeloma. You pick the correct answer. And we're moving on to red blood cells next. So I think I'm going to take a break at this point in the video and we'll fire up on this slide in the next set of notes. Thank you.